ora koutou. Ko Sue Brewster taku ingoa. Good afternoon, everybody. My name is Sue Brewster, and I'm the Executive Director of Auckland Medical Research Foundation, the largest independent funder of medical research in New Zealand. And in the last 65 years, we have awarded over $84 million worth of funding to medical research, which is just fantastic. I recognise a number of our supporters in the audience, and I'd just like to say thank you so much. We really couldn't do what we do without your support. And more so, our medical researchers can't do what they do best, and that's medical research. So thank you very much. 100% of your donation goes to medical research, and that's because all of our administration costs are covered by an independent funder. Rest assured that every single dollar you give will go directly to the cause that you want to support. So thank you. So today we are here to hear about the latest in cancer research, and we have two fantastic speakers in the lineup. So I'd like to introduce both of them. Our first presenter is Associate Professor Michael Hay, who is a man who wears many hats. One of those hats is as a valuable member of our AMRF Medical Committee, and all of our medical committee are volunteers. And the other is as Director of Auckland Cancer Society Research Centre at the University of Auckland. Mike's research is focused on improving cancer treatments and looking at the microenvironment within tumours to identify why they might be resisting current therapies. Our second presenter is Professor Mark Elwood, who as Professor of Cancer Epidemiology at the School of Population Health has written over 300 scientific publications and several books. Mark specialises in cancer control, causes and prevention, as well as screening and early diagnosis. And today he will share with us his learnings over the last years. Put your hands together and give a warm welcome to Associate Professor Michael Hay.
Thank you very much, Sue. Ina mana, ina reo, tēnā koutou, tēnā koutou, tēnā koutou. Ko Michael Hay, toko ingoa, hei kai whakahere aho ki Auckland Cancer Society Research Centre. Thank you very much, everybody, for coming. My name's Michael Hay. Thank you, Sue, for the kind introduction. Today I'd like to talk to you about some work that has been ongoing in the Auckland Cancer Society Research Centre, and which has been generously supported by Auckland Medical Research Foundation as well. So I just would like to start with a brief overview of cancer and some of the positive things about this. And here is a representation of cancer survival in New Zealand and the rates of cancer survival. And you can see that across the many diseases there are very, very different circumstances and outcomes. The point I'd like to make today, of course, is that across all cancers, from over a 40-year period from around 1972-ish through to the current day, the rates of long-term cancer survival over 10 years have improved from around 1 in 4 to well over 50%. And that's a remarkable and steady gain that can be attributable to multiple causes, not least of all improved screening and detection, improved treatments, improved follow-up, and a wide variety of impacts. And I think that's a very positive thing, but obviously there's still a lot to do across the whole range of improvements that can be made for patients and for people who are diagnosed with cancer. Our area of expertise is drug development, and we are looking at cancer as a disease, and across all of those multiple diseases, and you can think about almost up to 200 separate diseases, which we can identify some commonalities. And if I look at this chart and sort of try and break it down for you, cancers are typified by a loss of control, and that control is around how they receive messages to grow, how they evade the mechanisms that normal cells use to control growth, that they become active and engage in invasion through surrounding tissues and can also move out of the site of origin and metastasize to distant sites. They become essentially immortal, and they have certainly can resist all the signals that would normally tell a cell to die in an appropriate context. And they also recruit their own blood supply to create an environment that they can survive in. And there are some more recently defined features that also typical of many cancers. They deregulate their cellular metabolism to cope with the environment in which they find themselves. So often they're finding that because of their rapid growth and because of the poor blood supply, they often are short of nutrients. They can adapt their metabolism. They're essentially invisible to the immune surveillance that is constantly in action in our bodies. They are often inflamed, and that promotes further malignancy. And I guess one of the underlying features is, in fact, the genomic instability that leads to more mutation and the evolution of cancers. And I guess it's a moving target. And here is a cartoon that just demonstrates that from a single mutation, there will be an evolution. It might be as many as 30 generations before a cancer is detectable. And so over this period of time, the cancer is growing in a stressful environment, adapting to that and changing. And it's going to eventually be detected somewhere in this region. In the meantime, or thereafter, it has metastasized and has gone on and will keep growing unless treated in some way. And you can think about this in terms of an evolutionary pressure. The environment drives evolution, and that also encourages diversity that can respond to that environment. And if we look at this diagram, which is just following the time of starting from a single cell with a chromosomal problem or mutation, and you can see that it acquires more drivers, if you like, of this cancer. And some of these die out, some of these clades or clones don't survive, and others will survive. And so whilst most of the cancer is represented here from a common ancestor, there are other evolutionary groups of cancer cells, and so they're not all the same. So you have a heterogeneous genetic background. And I think it's best exemplified if you look at, say, I'm sure many of you have looked into Ancestry and tried to do some family tree tracking. And of course, if you were to sort of say, well, do Zara and Prince Harry represent their distant ancestor, Queen Victoria, you might go, well, there's a connection, but they're quite different people and they will respond quite differently to their circumstances. And I think that's a convenient metaphor to consider the heterogeneity that you'll see within a tumour. And it's also, so there's this microenvironment. Cancer tumours are not simply groups of cells of all the same evolution. There's cancer cells. There's the normal cells that support these. So endothelial cells, fibroblasts, all sorts of other cells, immune cells that are all mixed intimately in this relationship, which we try and capture in this cartoon. So it's an environment, it's genetically flexible, it's very disorganised, and it's invisible to the immune system. And you can see that because of the poor blood supply and the strong demand for oxygen and nutrients, there will be gradients of these nutrients, and there is a term called hypoxia, which really just means lack of oxygen. So these cells are under stress, and they will respond to that stress. And also you will see in terms of drug delivery, this is not a particularly well-served environment for drugs to move into that from the bloodstream. And again, I'm sure many of you are gardeners, and I think if you just think about your garden, which you've tended carefully and you have all your plants growing appropriately and you've got the irrigation system going, well, your tumour microenvironment looks more like this. The irrigation system's broken. The weeds that are invading and they're growing, you can still see. There's somewhere in there's some roses and there's some other various plants, but they're being strangled and lost. And so that is kind of a good metaphor for what might be happening in the tumour microenvironment. So this lack of oxygen, the tumour hypoxia, is a consequence of the tumour trying to recruit and attract blood vessels to supply it with nutrients, and whereas a normal bloodstream has a distinct architecture that allows for diffusion of oxygen and nutrients, the chaotic architecture you can see here and also over here leads to these hypoxic cells, which you can identify, and they're always usually at some distance from the blood vessel, not entirely, because sometimes these blood vessels just constrict because of pressure within the tumour, or they leak, and therefore the flows of oxygen are not particularly good. And you can see here, compared to normal tissue where you have this nice architecture, where you have an artery leading down through an arteriole into a capillary and out to a vein. Here we've got all this lots of dead ends, lots of loops, lots of short processes that really go nowhere, and you can see how inefficient that might be. So that is one of the problems of the tumour microenvironment that we have spent probably 3 decades trying to understand and trying to work out what its impact is. And certainly when we come and look at the pillars of cancer treatment, surgery, chemotherapy, radiation, and now more latterly immunotherapy, you can see that in fact the microenvironmental factors, the heterogeneity of those tumour cells, the fact that you're in a hypoxic environment which is stressful and is acting as an evolutionary stress, can defeat each of these modalities. If we think about in terms of which of these are used most often, surgery is in fact the most successful treatment for cancers, and it often is because they are discreet, they are often very easily accessible. Then this is followed by radiotherapy, again is used very often, and chemotherapy less often. More often than not, these are all combined into a schedule of treatment, but it just gives you some sense of the distribution of therapy with intent to cure. And of course, the data I have here is a little old and it hasn't really taken account of the tremendous impact that immunotherapy is currently making on cancer treatment. Just thinking about some of the various modalities of treatment, the new generation of targeted cancer therapies are in fact incredibly precise, and they can have some dramatic effects. And you can see here that this is a patient who's metastatic melanoma with advanced disease, and the cancer is driven predominantly by a mutation in one of those oncogenic mutations that drive the cancer growth. And you can see treatment with a targeted treatment that stops that particular pathway of growth leads to this remarkable remission, and you can see what a tremendous benefit that has achieved in that period of time. Unfortunately, the tumour heterogeneity will actually defeat many of these agents, unfortunately, and this patient obviously relapses because some elements of that tumour are not responsive to this incredibly precise therapy. And you can see that occurring, although the treatment does provide an advantage in blue over the standard of care in green, most patients are not seeing long-term benefit. There is a subset for whom this treatment is working, but again, you can see the challenge with just applying that particular targeted therapy. Immunotherapy is changing the game dramatically, and this cartoon here is just meant to represent the idea that tumour cells do present antigens which could be recognised by the immune surveillance system and detected as foreign, and that they then can go on and prime the soldiers, if you like, who go around and sort out the problems in your body, so these T cells can be activated. But there is a very well-defined handshake system that stops the T cells running out of control, running amok, and so many T cells find themselves inactivated. The use of some of these immune checkpoint blockade inhibitors, such as ipilimumab, can bind and disrupt that particular handshake and allow another handshake that activates the T cell, allows it to go out throughout the body and identify these particular tumour cells and get rid of them. And indeed, you can see here that we're looking at, again, metastatic melanoma, and you can see that for patients with advanced disease who are treated with ipilimumab alone, there is a proportion of patients that will achieve long-term survival, essentially long-term disease control without symptoms. And when we look at another one of these immune checkpoint inhibitors called nivolumab, which affects a different handshake, you can see that there is again significant benefit. And when we combine the two, you can see that approximately 4 in 10 patients will achieve a long-term survival. And that is a dramatic effect. That is a tremendously different effect from 5 years ago when there were very few options for these patients. And so that is a tremendous game changer. Radiotherapy is also used very widely. More than half of the patients who have cancer will receive radiotherapy, and of those, a majority will be treated with curative intent, either alone or in combination with other modalities of treatment. It has the advantage it can be used across many different tumour types, and there are a variety of different technologies that can deliver this. It's also pretty economical in terms of its fraction of the cancer budget. It's relatively low. So it is a good therapy, and it has particular application. And indeed, much of the advances in the last 20-odd years have been driven by technology. Improved technology has given improved treatment responses. And we can see here in 2003, this is per patient data probably from last century, but just radiotherapy alone is achieving local region control, and this is in head and neck cancer patients. Whereas if you add in chemotherapy either afterwards or concurrently, you can achieve increasing control, and that very much maps to survival as well. So that is quite effective, with 75% of patients responding positively to the treatment. And over the last 20 years, the technology has increased. The ability to deliver that radiation to the tumour, sparing normal tissue, which is very important in head and neck cancer, has improved dramatically, and the survival rates have actually increased as well, just incrementally, but steadily going upwards. So that, again, is a very positive trend. Looking forward, further advances in cancer treatment are going to be driven by combinations of these therapy modalities. And you can see in this cartoon the various sorts of classical chemotherapy and genomically targeted or therapies all provide improvement or some degree of protection from cancer, but are not necessarily long-term solutions. The real game changer seen in immune checkpoint therapy really will be a positive outcome for a certain proportion of patients, but not all patients. And again, how do we move the green line up to the red line? And again, we will need to focus on the mechanisms of resistance, such as hypoxia and genetic heterogeneity, and also the DNA repair mechanisms that lead to these highly mutated diseases that have lost control. And so I'd like to now focus on some work that we've been doing over literally 3 decades in our laboratories, trying to use hypoxia as a therapeutic target. It is pretty unique to tumours. Most other locations in your body are reasonably well oxygenated. We can see here these in green, these are areas of hypoxia that we've imaged, and they've sort of formed these circles around what are, you probably can't see, blood vessels in the centre and well oxygenated tissue surrounding them. And then as you go out along the periphery, you can see this tissue. Many tumour types have hypoxia, but it's very variable. And you can see from these, this is a degree of hypoxia across a whole range of different diseases, and you can just see the huge variation there. But it is a therapeutic target, and we can see here some data from Denmark, where looking back at patients who received radiotherapy alone, and for whom the tumours could be stratified into being more or less hypoxic, you can see that the less hypoxic tumours, or the patients with those less hypoxic tumours, fared better than those with hypoxic tumours. And that was a consequence of the failure to control the tumour within the radiotherapy field, most oftentimes. And again, the hypoxia tumours were less controllable. And that could be manipulated therapeutically. And you can see here when you separate the 2 groups of patients, and you can treat them with a relatively simple agent, nimorazole, which is works against anaerobic bacteria, a bit like metronidazole. You can see that for patients that don't have hypoxic tumours, it has no benefit. But for those patients for whom their tumours have a significant hypoxic fraction, the nimorazole acts to redeem or to make that radiotherapy more effective, and that has a dramatic effect. Unfortunately, this drug's only licensed for use in Denmark and has been so for the last 15 or so years. It is under review in Europe to be included with radiotherapy regimens. Our take on this is to look at that and go, yes, we have developed drugs that can be used in the same manner and targeting and killing hypoxic cells, but is also to look at those hypoxic cells, which are treatment resistant, as a very specific location, a postal address to which you can send a drug, which is deactivated as a thing we call a prodrug. It's non-toxic, non-effective. When it diffuses into the tumour, where it's activated by enzymes in the absence of oxygen, releases an active metabolite, which could be something like a cytotoxin, which goes and kills the cells and surrounding cells, or it could be one of these exquisitely targeted molecular agents that are being developed more recently. And this cartoon just shows you what we're trying to achieve, where we have over here the blood vessel surrounded by tumour cells, and the prodrug diffuses out through into this hypoxic zone. It's activated and then returns back and can kill or inhibit the growth of the surrounding cells. And I just want to showcase some work from two very talented investigators in our laboratories, Associate Professors Adam Patterson and Jess Smale, who've taken a very targeted agent that targets one of those growth signals, which is driven through the epidermal growth factor receptor. And this is a receptor that sits on the cell wall and has a site outside which then can recognise proteins that can come and stimulate that and set off a signalling cascade. And it targets, and it has this intracellular domain where it has an active site which the drug has been designed to just fit in there. Here's a better example of how that signalling pathway works. So the receptor out here can be bound by a molecule that stimulates this growth pathway. And whether through an oversupply of the stimulation or an overexpression of the receptor or a mutation that leaves it permanently on, this drives growth through this signal pathway. And if you inhibit that intracellular domain, you inhibit the function and you inhibit the signal. And the cell, which is essentially addicted to this signalling pathway, will then certainly stop growing and most probably die. Here's another cartoon just demonstrating how that might work. And again, you can see that the drug diffuses in out of the blood system to these hypoxic cells where it's activated, and then it can then start to drug the tumour with the released molecularly targeted inhibitor. And it can then diffuse from this zone. So we've killed that treatment-resistant portion of the tumour, and so it can also diffuse and start to target more of the cells with it throughout the whole tumour. You can see here a picture of this again, just showing areas of hypoxia that have been stained within a tumour, and you can see that it's not through the whole tissue. And here Adam and Jeff have mapped the activation of the drug from the prodrug, with the red being the highest concentration, and you can see that it has diffused through much of the tumour from those areas of high concentration. Now, Tarloxotinib, as it's called, has been taken into phase 1 clinical trial, firstly in the US and also in 2 sites in Auckland, and that's been led in New Zealand by 2 of the researchers from the Auckland Cancer Society Research Centre, Associate Professor Mike Jamieson down in Hamilton and Professor Mark McKeague in Auckland. It's also gone on to phase 2 clinical trials, where it's still currently in trial, looking at its ability to work with a particular subset of non-small cell lung cancers that are driven by these mutations in that signalling pathway, and also in recurrent or metastatic squamous cell carcinomas of the head and neck or of the skin. And whilst those are ongoing, what Adam and Jeff have been able to do is to bring it back home to New Zealand, and with Dr. Andrew McCann from Auckland City Hospital are hoping next year to start what we call a window of opportunity study to look at the combination of this drug with a form of radiation in head and neck patients prior to them receiving the surgery they would normally receive. And so this gives us, the researchers, an opportunity to see how the drug works in combination with radiotherapy. And it is an active drug. The preliminary analysis of The phase 2 trials are showing at least some partial responses in patients. This is when it's just given alone, and so it is certainly working on mechanism within these patients. And you can see the sorts of effects that are being achieved where this patient has this pleural effusion and tumour mass, and how after approximately 12 doses of the drug, that has been cleared. So this is ongoing research, and there's no definitive answers as to the efficacy of the drug at this stage, but it is a very positive signal. I'd just like to then, having looked closely at a little bit of research from the centre, step back a little bit and just talk about our centre overall and what we're trying to achieve. And one of the big things that we are trying to do is to impact patients with new cancer therapies. And we've had a measure of success over many years. And we can go back to Bruce Kane, who developed Amsicrin in the 1970s, and it was finally approved in 1983, that also spun out a series of other DNA-binding drugs. If we go back far enough, of course, the structure of DNA had just been described. Cancer was really only known of as a disease that was constantly replicating, and DNA was part of that, so targeting DNA was the target to choose. And so a flurry of activity, clinical activity from the centre led to one approval. We're also looking at immune stimulants, and a drug here called DMXAA was went all the way through to phase 3 clinical trial in Europe and New Zealand with Novartis, but was ultimately unsuccessful. Further work with the DNA binding drug has actually led to a rather novel application where it's used to sterilise blood cells and remove viruses. There's been a big body of work around these targeted agents, we call them kinase inhibitors, that target those signalling pathways I mentioned, and indeed work with Pfizer over several decades has led finally to the registration of one of these agents. It's available in the US but not currently in New Zealand. And another agent has been segued sideways into companion animal therapy. We have a very strong TB program which has led to clinical activity. Another program with immune stimulants has also been licensed into clinical trial. And again, we have this strong area where we're targeting these hypoxia as a therapy, and I've mentioned the progress with Tarloxotinib, but there is another agent. And there's another whole program of work following in behind this with the next generation of agents. How have we done this? And again, I'm just trying to sort of point to the fact that it is very challenging to go from preclinical research into clinical research. We've been able to utilise the universities, commercialisation arm, but we've had to be agile and quick thinking. We've worked with international charities, we've worked with big pharmaceutical companies where we've partnered with them, and that's been very much a learning curve. We've taken advantage of their wealth and knowledge and been able to advance our ideas very successfully. We've licensed it out to a range of commercial companies, from big pharma such as Novartis to tiny small companies that have been set up around the world. And again, that has led to successful access to clinical trials. And we've even set up our own startup companies in New Zealand and then let them head off to overseas, taking the drugs with them in an effort to try and raise the money to conduct these trials. And I hope today just to convince you that in fact academic laboratories have a very important role to play. You know, our mission statement is to improve outcomes for cancer patients in New Zealand and globally. And we do this by understanding the mechanisms of disease and resistance to treatment. Our job is to try and translate these new ideas into drugs, into the clinic, and also train the workforce while we're at it. And so there's some opportunities that an academic lab has. We often have longer time frames. We don't try and compete head to head with the big boys, if you will. There are niches we need to occupy, and these ideas aren't necessarily the main thing in front of you. We've been very productive, and perhaps the one thing that's missing is how are we developing drugs in New Zealand for New Zealanders? Inevitably taking our drugs offshore means we lose some of the development approach, some of the local flavour and context, and also the ability to actually move these into use in New Zealand. And that's a big challenge for us. I'd just like to finish by taking this opportunity to thank the AMRF and to thank you, the donors and supporters of the AMRF. Over, I think it's 25, 26 years, the AMRF has very generously funded a lot of research in our laboratories, particularly early career researchers. And I think if I add this up and convert it to today's dollars, it's over $3 million worth of research has been funded in our centre. And so we're extremely grateful, and I think that we've done a reasonable job in trying to convert that into great things. And it's not necessarily the quantum of money, it's the fact that small portions of money can be very effective as glue that holds together bigger programs that we can leverage and take forward and develop drugs, which will cost tens of millions of dollars to develop, but it is in fact a very important glue. So thank you very much. So I'd like to thank you for your patience and attendance, but also for your generosity and support. Thank you.
Thank you, Mike, for all your work, your team's work, and for giving us all hope. And we can see by the statistics too that the improvements in cancer treatments is certainly on that trajectory. So thank you. And I'd like now to ask Professor Mark Elwood to come forward and do our second presentation on the latest in cancer research.
I'm going to give you a presentation which may sound completely different, but the first thing I would say is that Michael and I have the same objective. We're both trying to do research which will benefit everybody in New Zealand. Mike's emphasised developing new drugs and improving the outcome of cancer patients, and that's going to be the focus of my topic as well. I would add one more dimension, that part of my job is also to try to reduce the number of cancer patients so as we don't have to go to this sort of extreme. But there's two ways in which we can improve things. One is to make new discoveries, and that's what you've heard about. The other is to use the knowledge we already have more effectively, and that's basically what my talk's going to be about. And I think we have to do both of those, and we can do both. The diagnosis of cancer, as unfortunately many of you will know personally or through the experience of friends and relatives, is a life-changing event. And amongst other things, the newly diagnosed patient is faced with a huge amount of information, which is confusing, which is conflicting, which is frightening. And how do we navigate our way through this information? And we may be forced to make some big decisions about our own fate, our own treatment very quickly. Now you may think, well, I just asked my doctor. Surely doctors do this all the time. They must know all the answers. But believe it or not, your doctor may also be confused by all the information, may also spend nights awake working out what would be the best for this patient. So I'm going to talk about two projects funded by AMRF, rather than a whole area of research. I'm just going to talk about two particular projects. One of which is to try to work our way through that minefield of information. And we're focusing on the situation with breast cancer. And the project asks the question of, from the information we know about a breast cancer patient who's just been diagnosed, can we predict their outcome? And will the prediction of that outcome guide us in what treatment we recommend and how that patient and her doctor and her family manages their lives? Now, the only way we can predict what will happen to a patient is to study what does happen to patients. And you might think this is routine, but it isn't. We need extremely good information and complete information on what's happened to a lot of patients in our own community. So the starting point for this research is in the 1990s. It was at that time that the doctors in Auckland and also in Waikato, who were treating breast cancer patients, realized they could learn a lot if they recorded precisely all they knew about that patient and their disease and their treatment, and then if they followed that patient through the rest of their life to work out how they did. So the research I'm going to be described is dependent on data systems we have for over 9,000 patients in Auckland and over 2,500 in the Waikato who were diagnosed between the year 2000 and the year 2014 and have been followed for the rest of their lives. Now, what are the factors that influence breast cancer? Well, we've involved a lot of these in this project. There's the woman herself, her age and her ethnicity, things about the cancer, its precise cellular type, whether it's got receptors to estrogen and progesterone, which would suggest that hormonal treatment with agents like tamoxifen may work. If it's got receptors to HER2, which is a genetic mutation, which, if present, shows that the tumour may respond to Herceptin. And the most important factor is how far this cancer spread at the point of diagnosis. If there's a breast lump, how big that lump is, if it's spread to the nodes or further, or into the blood vessels and lymphatics. And then comes the mathematics. What we do is look at each of these factors and assess each of those factors, do they affect the long-term outcome of the disease? And in what direction do they affect it, and how big is the effect? And then, and this is the more difficult part, we put all those factors together to see if, by using all that information, we can predict outcome. Now we can, and the interesting thing is we can distinguish between patients who have a predicted 10-year survival from breast cancer of more than 90%. That's really a pretty good outlook. Down to a group of patients whom we can predict will have a long-term outcome of less than 5%. That's a pretty big range. Now, the great majority of patients, these are our 9,000 patients, and half of them are in that 90% plus category, which is good. But as you can see, we've got small numbers of patients who have really poor outcomes. And then the test of whether what we're doing is of any value is we have to compare the predictions with what's actually happened. And the ideal situation we would like is that we can look at different groups with the predicted 10-year survival on the horizontal axis, and it should relate to the actual 10-year survival. If it was a perfect fit, we would get the line shown here, straight line from 0 up to 100. This is what we actually get. In the larger groups of patients who have outcomes of 65, 75, 85, 95%, the prediction is almost perfect. What we observe is very close to this. This would be quite helpful. So in other words, from the information available at diagnosis, we can say to this woman and her doctor that your likelihood of surviving this disease for at least 10 years, which really means that your long-term outlook is very good, is over 95%. And that's tremendously useful information. Now down the lower end, the vertical lines are bigger, which just means the groups of women are smaller. The prediction is not quite as good. It tends to be pessimistic. If we predict 25%, the actual result is about 38%. Now this means that if there's some way in which we could improve what we're doing, if we could involve some more information, or if we could use the information we have in a slightly different way, we may be able to get a more accurate prediction. And in doing so, we will understand more about how these factors work and interact. But it's pretty good. So this has all been done on a funded project by the AMRF, led by Esotophic, and involving a small team at Auckland and Waikato. Now, we're not the only ones in the world doing this. There are other people elsewhere in the world doing it, and the most well-established predictive fact model has been developed in Britain with a lot of international help, and it's actually used by doctors in New Zealand for this, to give them a prediction. But it's interesting that what they're using is based entirely on British patients diagnosed 20 to 30 years ago, and they're applying that to New Zealand patients. We are for the first time looking at what actually happens to New Zealand patients, and if that's different from the international experience. So say, this is our team. This is the British and international team representing researchers from 7 countries and 24 major cancer centres around the world. And so far, our model looks pretty well the same, or pretty well as good as what they've developed. But, as Mike was saying, you can't really compete with big teams. So we've joined them. And we've now got a project running with the University of Cambridge, which is taking the British developed model and the New Zealand developed model and comparing them and seeing if there are ways in which we can improve both of them. So this little project, which is 2 years AMRF funding, has led to this development and this international collaboration. Now I'm going to talk about a second project which we started this year, which will run into next year, which is also on this topic of predicting risk. And here what we've done, we've developed in our little team of 3 or 4 people some expertise in predicting outcomes of breast cancer. There's a much bigger group, very well established in predicting risks, and that's the group led by Professor Rod Jackson in cardiovascular disease, who's been working for 10 years or more on predicting cardiovascular risks. And his work is recognized as the best in the world, really, and is being used internationally as the best method of predicting heart disease and stroke risks. So we've combined forces, and we're going to look at 2 questions. One is, can we apply the cardiovascular risk system, which is used in general practice in New Zealand, can we apply that to cancer survivors? Because once you pass through the immediate treatment phase of cancer, your health risks, like anybody else's, are dominated by the risk of heart disease and stroke. So it's a very practical question. Can we simply apply the same system as we do for the general public to cancer survivors? Or should it need some modifications? And the second question we're going to ask is heart disease increased in cancer survivors? And does that increase depend on the type of cancer or on the type of cancer treatment? And these are important questions which are being asked all around the world, but on which there's no definitive answer as yet. And we're going to do that by linking up big databases. And we can do this very powerfully because of the big development that's been in these risk models for predicting cardiovascular risk. So we can identify through the National Cancer Registry patients who are cancer survivors who are several years past the initial cancer phase for treatment and are also involved, have had their cardiovascular risks assessed by their GP and are in the big system. And we reckon there'll be at least 15,000 patients whom we can study. There's another database called Variance, which is slightly less detailed, but is still very valuable for cardiovascular risk prediction. And we can link all cancer patients to that. And there'll be about at least 72,000 patients in that study. So the team for the new project, again, the project is led by ESA-TOFIC. Mike talked about, the importance of developing investigators. ESA came to this country from Afghanistan about 10 years ago. He did a PhD in health services research in Wellington, but he had no previous experience in cancer research until he came to us. He has led the project on breast cancer prediction, and he's now leading the project on cardiovascular and cancer work. And this involves a wider team, including our colleagues with cardiovascular disease expertise, statisticians, and people with expertise in Maori and Pacific Health. Now, this is one small AMRF investment. We've received $300,000 from the AMRF over 4 years. This research money acts as a catalyst because it more or less forces the universities to give the time and expertise of people like me to the project. So I estimate that the universities of Auckland, Waikato, and now Cambridge have brought in about $450,000 in support. And of course, it's really dependent on the support of the registries over 20 years, which is even smaller amounts of money donated by a whole range of charities. And of course, it's dependent on all the patients and all the healthcare staff who were involved in that. Let me sum up. As I've said, what I'm trying to do is to improve how we use current knowledge better, which is as important as what Michael is doing, is increasing our current knowledge. In New Zealand this year, about 21,000 people will be diagnosed with a serious cancer. And of those, about 8,000 will die from their disease within 5 years of diagnosis. Now, at least 10% of those deaths, at least 800 deaths per year, could be prevented if we simply used the knowledge we have better, without any new knowledge, any new drugs. Why can I say that? Because that's the experience of Australia. They have the same expertise as we have. They're dependent on the same international knowledge, and yet their survival rates from almost all cancers are much better. And overall, their death rate from cancer is 10% less than it is in New Zealand. And you can't point to any one thing. It's the way the system works, all the aspects of treatment, from the first recognition of a problem with cancer to the work through the general practitioner and referrals, testing, diagnosis, and so on. We had a very interesting email discussion about setting up this session because it started with the phrase bench to bedside, which has been used for years by researchers, and it covers a very important aspect, which is the necessity to relate the bench research in the laboratory to the bedside research on the patient. I have a very distinguished colleague who's involved, like Mike is, in new drug development, who pointed out to me one day that the really important thing was not bench to bedside, it was bench to bedside to boardroom. Because it's in the boardroom that the decisions are made whether to fund a drug, whether to make it available. Those are the critical decisions. And then I said, but that's not enough. Because even if the politicians agree on a policy, or we as a profession agree on a policy, it has to work. It has to involve the whole community and getting people doing the right things, and that's where we get to better care. I've recently had several reminders of this. Like most of you, I've just had my second COVID immunization. So I've received a vaccine which was developed in a laboratory just about a year ago, in which the definitive research to show its effectiveness was finished only last November. And this is to protect against a disease which was only first recognized about 18 months ago. Now that is, I think, the best example there's ever been in the world of bench to bedside to boardroom to better care. It needed the bench research to develop the vaccine. It needed the bedside research to understand the illness. It needed the boardroom or the cabinet room decisions to get the vaccine to New Zealand. It also needed the distribution, so as I could go to my local GP surgery and get the vaccine. So that's how it should work. But unfortunately, it's not how it always works. Last week, I think, you may have noticed in the newspapers the New Zealand government authorised the addition of folic acid to flour to prevent neurological defects in babies. Although it'll take apparently another 2 years for the industry to actually do it. Well, that's interesting because that's based on bench to bedside research. Actually, research which was the topic of my first research in the 1970s. But the key research was completed in 1991. It's taken 30 years to go from the research to the boardroom decisions to better care for everybody. Similarly, last week I got a letter from the Ministry of Health offering me a screening test for colorectal cancer, which is good. That represents another health service development based on excellent bench research and bedside research and epidemiological research to show its effectiveness. I felt a little smug about that because actually I had my first screening test for colorectal cancer 12 years ago because I lived in Canada at the time and I was involved in setting up the screening program in Canada. Now, as it happened, it showed quite a serious, not cancerous, but precancerous lesion, which was removed. So I've had the benefits of the screening some 12 years before I would have had it if I'd just lived in Auckland. So thank you for letting us both talk about our research. I think we've shown you that research is important, that funding for research is essential, and even fairly modest amounts of funding can relate to much bigger and bigger things.
Thank you, Mark. And I think also from Mark's presentation today, while we know we've got these big data sets that we can now use to help predict outcomes for people, the fantastic thing about our researchers, like Mark, is he knows behind every single data set is a person. And what he cares about is the outcomes for that person. So while they might be analysing and predicting and survival rates and all that sort of stuff, it's actually about improving the outcomes for all of you as people. I think the one thing I always take away from these presentations is hope. And I think you can see from the trajectory of research outcomes that Mike has put up that even though research takes time, the results, once you have got to a certain level, take off exponentially. I hope everybody that came today has a little takeaway, a nugget of information that they didn't have before, and that helps everybody with outcomes, and especially in the cancer research and cancer treatment space. So thank you so much, everybody, for coming, and I'd like you to put your hands together, please, for our presenters today.